Hi everyone. So my name is Jaman Mahamud, and today I'm going to be presenting to you risk mitigation strategies and increased global access for natalizumab to treat multiple sclerosis. And I'm from the Bronx High School of Science. So this is a brief self-introduction. I'm extremely proud to become an incoming junior at the Bronx High School of Science, and I'm very into neurology and insulin secreting beta cells and alpha cells. And currently, I'm doing some research at Columbia University, and we are working on ways to prevent islet dysfunction and immune responses against islets. Apart from academics, I live for lifting. I'm the co-leader of Bronx Science Health and Fitness, and I work at many places, ranging from marketing manager and intern at Montefiore's Bold Cancer Program, Mount Sinai Med Docs Plus student, and I'm also assistant physical therapist at the Bainbridge Therapy Care. Healthcare is always something that I've advocated for as a varsity congressional debater at Bronx Science. So this is some background information. Multiple sclerosis is actually an autoimmune disorder and it affects 2.8 million individuals, where the immune system actually fights the protective myelin sheet that coats the fibers, and the damage conducted to these protective coverings actually disrupts the communication that happens in between the CNS. So we can see here that there are various symptoms: fatigue, cognitive changes, more, right? And the prevalence and demographics of multiple sclerosis are actually that's most commonly diagnosed with a female to male ratio of 3 to 1. And MS is actually more prevalent in temperate climates. And you can see in this diagram to left, to right, and normal versus a multiple sclerosis is that the multiple sclerosis has a damaged myelin sheet. Okay. And the course of disease and potential treatment is that in a disease course, there's going to be RRMS. And this is going to be basically periods of relapse, which flare-ups, also followed by periods of remission. And then there's going to be SPMS, and this is gradual worsening of symptoms after an initial RRMS phase. And there's going to be PPMS, and this is going to be a steady progression of disability without distinct relapses. However, there is a research and treatment for this, and it is called natalizumab. Okay, so how does it work and why does it work effectively? So there's cell adhesion inhibition, right? And this is natalizumab when natalizumab actually binds to particular subunits of white blood cells, the alpha 4 subunit, and they'll be interfering with this adhesion process. And natalizumab actually inhibits the white blood cells from causing harm. And the brain and spinal cord protection it actually works as a bouncer, natalizumab, and it prevents white blood cells from passing into sensitive areas of the CNS. However, there are huge risks associated with natalizumab, and one of them is PML, another is infusion-related side effects. So, what do we have to do? We have to mitigate the risks of taking natalizumab and increasing global access to it. Okay, so this is our presentation body, risk mitigation for natalizumab, and this is going to be personalized EEID for natalizumab. So what is EID? It actually involves adjusting the dosage according to the patient's characteristic so that the therapeutic level of the drug should also be maintained and also at the same time it meets with a minimal chance of risk. So why EEID? So we have the traditional dosing of natalizumab is every 4 weeks. However, the use of EID confers several advantages, and one is it lowers the risk of progressive multiple PML, right? And a very rare, but probably lethal brain infection related to using natalizumab. Okay, so our EID MS personalized natalizumab dosing study was that we had actually an objective of getting the patient satisfaction of individually tailored extended interval dosing of natalizumab were actually evaluated in RMS patients. And the study design was a randomized control trial. And we had an EID 10 group where the patients with the target troph concentration of 10 micrograms per milliliter and extended dosing intervals. So the standard interval dosing group was every 4 weeks for the control group, and patient reported outcomes were the standard quality of life, fatigue, treatment satisfaction, etc. And our analyzed relapse rate was the number of documented relapses during the study period. Okay, so our study continued is that we had a follow-up for, and the duration was 24 months. And we had clinical visits, MRI scans, laboratory tests at regular intervals. And our results for the EID-10 group was that they had a lower ARR compared to the SID and had a higher patient satisfaction due to less frequent infusions. However, for our SID group, we had results that were expected to be based on historical data regarding efficacy and safety of standard dosing. And our discussion was that EID can actually individualize natalizumab treatment at this frequency to optimize balance between efficacy, safety, and patient experience. And presentation body and risk mitigation number two is that using combination therapy, we can actually use inactivated vaccines like hepatitis A and B and the COVID-19 vaccine. And these are actually really safe and effective in MS patients treated with natalizumab. However, there's no evidence supported that patients under natalizumab medication at the same time of completion of vaccination schedules had impaired vaccine immunogenicity. This may actually indicate that in highly active patients with MS, natalizumab might be used concurrently with vaccination. So our conclusion is that natalizumab is an effective treatment for multiple sclerosis, but can only be when its risk factors are decreased. This risk mitigation can come from extended interval dosing by reducing PML and by allowing the drug to be maintained. And this could also be using combination therapy. And we should also look into increasing global access. So we have telemedicine, right? And this will allow us to um, put healthcare services to be delivered remotely. And this could include video calls, consultations, monitoring from afar. And this could have various benefits from geographical barriers being completely moved away and improve follow-up and adherence of patients. And we can actually collaborate with NGOs and partner with them for drug distribution. And we could do this by drug procurement. And we can actually subsidize drug costs for eligible patients through the NGOs. And this can actually reach remote places and deprived areas. And we also need to increase the educational awareness of MS. Okay, so as you can see, these are my references. And I want to acknowledge the Global Health Leaders Conference at Johns Hopkins University for giving me the opportunity to present. And I also thank Neuro Inc. for allowing me to conduct original research. And I want to thank you guys for watching. So my name is Jaman again, and this is how you guys can contact me. So thank you guys so much.